Hello everyone. Today's video is going to be about dyspepsia. Dyspepsia is basically the problem which comprises of number of symptoms, which comprised of postprandial fullness, bloating, GERD, epigastric fullness, and discomfort, epigastric pain after meals and before meals. So there are a number of symptoms that comprise dyspepsia. In this video session, we'll be discussing how dyspepsia uh, have been tested in USMLE exam and how to deal with patient in real life when we are dealing with dyspepsia. So whenever the patient presents to us, there are some symptoms that are really common. It could be epigastric pain, it could be bloating, it could be postprandial fullness, it could be early satiety, it could be nausea, it could be the pain could be postprandial or the pain could be relieved after the meals. So these are number of symptoms and these have to be in a specific duration, which is 1 month. The symptoms should comprise of around 1 month history. So after then we label it as dyspepsia. So when the patient is presents to us, what the first thing we do is we have to characterize whether this patient has high risk for malignancy or low risk for malignancy. Why we are using the term malignancy? It's a big term. So the thing is that few malignancies in GIT presents with the same symptoms and they have some alarming features and they occur in some specific age groups. It could be age more than 60 years and it can present with odynophagia, which is pain when you eat. It could also present with dysphagia, inability to eat. It could present with iron deficiency anemia. It could present with melena, which is a maroon color soot with bad odor. So these are various symptoms that we have to rule out when we see the patient with dysphagia or dyspepsia. So once we rule out the symptoms and alarming features, then we are basically clear that this patient is not having higher malignancy risk or he have the higher malignancy risk. There I have to take a call. I'm really sorry for the interruption. I'm really sorry for the interruption. So, yes, we were talking about malignancy. So, if the patient has higher malignancy risks, then we go straight to the invasive investigation, which includes endoscopy, and then if there are lesion or ulcer, then we have to do biopsy. If there is no low malignancy risk or no alarming features, then we can definitely go for non-invasive testing, which is H. pylori testing. And for H. pylori, there are two types of tests. One is urease breath test, and which could be next as stool antigen for H. pylori. So these tests are basically really essential. Ruling out H. pylori is very important because H. pylori can further lead to ulcers, and then it can also leads to maltoma, so which is a cancer. So that is why we have to rule out H. pylori in earlier disease. So once we are done with ruling out H. pylori with non-invasive testing, then we can go for trial of PPI. If we talk about the causes of dyspepsia, 75% of cases are basically functional, which means it is idiopathic. There is no set specific cause, but few cases are due to cancers, H. pylori, ulcers associated with NSAID use. So that is why investigations are important, and we have to go through the investigation according to the type of symptoms and alarming features and risk for malignancy, which we have already discussed. So if I go for repetition, patient has higher malignancy risk, we go straight for endoscopy and then biopsy. If patient has low malignancy risk, then we can go for non-invasive testing for H. pylori. If if H. pylori is confirmed, then we can treat the patient for H. pylori. If it is not confirmed, then we can give a trial of PPIs, and it is most probably caused by the functional or idiopathic changes, or it can be due to NSAIDs. We have to also rule out the use of medications that patient is using. It could be bisphosphonates that patient use for osteoporosis. It could be NSAIDs. So also go for the history of medication that are being used by the patient. Now, next in line is how to treat H. pylori. So, if we talk about H. pylori, there are two types of therapy. We call it triple therapy, and we call it quadruple therapy. If the patient has history of use of macrolides, then we have to go for different therapy, which is quadruple therapy. If the patient has not used macrolides, then we can go for triple therapy. If patient has penicillin allergy and he has used metronidazole, then we have to go for quadruple therapy. If he has not used metronidazole previously, then we can go for triple therapy. So these are basically variations in treatment of H. pylori, which are really easy. You just have to remember uh, triple therapy drugs that are used commonly. PPI is essential part in both of therapies, and next in line in triple therapy is amoxicillin or metronidazole. If the patient has allergy, we go for metronidazole. And the next is clarithromycin, not azithromycin. We have to use clarithromycin as macrolide. So these are triple therapy. For quadruple therapy, we change two drugs. We don't use amoxicillin, we don't use clarithromycin. It is replaced by metronidazole and tetracycline, along with bismuth subsalicyclate or bismuth sulfate, I guess so. So that's the quadruple therapy. So that's how we treat H. pylori. And once the infection is cleared, the patient is symptom free. After the patient is symptom free for 2 months, we go for stool antigen test for H. pylori, which confirms the eradication of the disease. If the patient has concomitant ulcer during the H. pylori infection, we definitely have to go for endoscopy, and there we have to rule out whether the disease has been eradicated or not. So we also have to remember about that. So if we go for a quick repetition of dyspepsia, dyspepsia has various symptoms. which or go on for like 1 month. The duration is really important. The history symptoms are epigastric pain, dullness, dullness, dull pain. It could be bloating. It could be postprandial fullness. It could be early satiety. It could be nausea. So these are some variations of symptoms that occur in the patients. After we have the symptoms, then we have to go for uh, um, characterization of the patient. We have to take the history. We have to rule out the alarmic symptoms. Alarmic symptoms are age more than 60, lymphadenopathy. Alarming system include dysphagia, which is inability to eat. It could be a dynophagia, which is pain when the patient is eating. It could be iron deficiency anemia. Definitely, it could be melena. It could be uh, fatigue. So these are the symptoms that we have to rule out. And if there are no alarming symptoms, then the next in line management is different. So no alarming symptoms, uh, ages less than 60, we go for non-invasive testing for H. pylori. If the it, if the patient has positive H. pylori test through urease test or hydrogen breath test, we go for triple therapy or quadruple therapy. If the patient has used clarithromycin previously, then we have to go for the quadruple therapy, which includes tetracycline and metronidazole with bismuth and PPIs. If the patient has not used clarithromycin and he doesn't have penicillin allergy, then we have to go for triple therapy. And if he has penicillin allergy and he has used metronidazole 2 previously, then we have to go for quadruple therapy. If metronidazole is not used, then obviously triple therapy. So these are basically variations in the H. pylori treatment. If the patient has no H. pylori, then we have to treat it as functional dyspepsia. And in functional dyspepsia, we have to give the trial of PPI. We also have to rule out other symptoms or medication history, which are NSAIDs, bisphosphonates. We have to find out the cause of dyspepsia. And if we don't find any cause, then we label it as idiopathic or functional dyspepsia. If the patient has alarming symptoms, then it's really easy. We just have to go for endoscopy and then we have to take the biopsy if there's ulcer. So that was the basic about the dyspepsia. I hope everything is clear. And I'm thinking to share the screen next time along with some flow charts. I've just learned the new feature, and basically, I'm not really good at the technology. So day by day, I get to learn new things, and I will try to integrate into my video sessions sooner or later. So thank you so much for the time you people give, and if you have any sort of questions, most you people are most welcome. So thank you so much.